today's webinar. We're very pleased to have Dr. Grace Yang here to speak on cytohistology of interesting head and neck cases. Dr. Yang is clinical professor of pathology and laboratory medicine at Weill Cornell Medicine, York-Presbyterian Hospital. And she's very experienced, has accomplished a lot on her CV, but specifically in head and neck cytology. She has had a book in 2013, the Thyroid Fine Needle Aspiration book, which is one I recommend reading. She's written many chapters for several other books in head and neck cytopathology, published numerous articles with more than 20 in the field of head and neck cytopathology. Has been a very active participant in the American Society of Cytopathology, presenting several microscopic and virtual microscopy workshops in this topic. And she's also been an international speaker. And she has collected many very interesting cases over her career, and it's quite a treat to be able to see them here today and hear her explain them to us. So without any further ado, I will turn the presentation over to her. Thank you, Dr. Yang.
Thank you for the invitation. First of all, I use triple tests. First clinical, then radiologic and cytology in the setting of the previous two. So I use the Swedish smear technique. And back in 1994, I published a paper observed nuclear area after air drying equals nuclear volume. And I use that a lot in dip quick stain. And then 1995, I published ultrafast pap stain. And so the Papanicolaou stain is well-fixed cells, three-dimensional. Ultrafast pap stain is rehydrated air dry cell. The advantage is cells are flat, all the blood has been humanized. So, and then Park Avenue Radial invited me through Dr. Knowles to offer immediate diagnosis in their practice in 1995. And they use a lot of CT FNA and ultrasound FNA. Ultrasound, mostly breast FNA. At that time, there was no core biopsy, so everything's breast FNA. And I'm supposed to offer patient immediate diagnosis. And Dr. Messina, Dr. Libeskind were the owner, and Dr. Messina did a lot of biopsy. And then I returned to Cornell and collaborate with Lennox radiologists, only head and neck. And Karen Free is my radiologist collaborator. And I'm going to show you in a case at breast FNA Park Avenue Radiology. So this is set up ultrafast pap, dip quick, and two-headed scope for a rotating resident. And I'm supposed to offer immediate diagnosis to everything. There's a case, breast FNA, dip quick looked like macrophage. But when I did ultrafast pap, it's not macrophage. It's lipid-rich ductal carcinoma. So it really saved me. And then the clues I use personally is dip quick, I use nuclear volume, and use RBC as a measurement. Background substance, metachromatic matrix, negative images, very useful. Lymphoglandular bodies, eosinophil, etc. Ultrafast pap stain I use for architectural features, nuclear features, and cytoplasmic features. So once I have this tool, I could diagnose everything. here's a periareolar nodule. If quick nucleoside, same as RBC, therefore it's benign. Ultrafast PET, granular cytoplasm. Therefore, it's granular cell tumor, confirmed by histology. Subcutaneous neck nodule, it's not a lymph node. And you see epithelium with small nuclei. And then you have multinuclear histiocyte. It's diagnostic for pyelonephrioma. This is the histology. Lymph node with thick hilum, and you have epithelium necrosis. Of course, it's metastatic carcinoma, and it make a cell block and do immunometastatic HPV positive carcinoma. And another lymph node with thick hilum, and it's positive. Well, what kind of positivity? It's ultrafast PET stain show cohesive cells. Vesicular chromatin promonucleoli look exactly like nasopharyngeal carcinoma. They need to confirm with EBER. It's confirmed. So that's how I signed it out. Tissue follow-up at Mount Sinai, confirmed. Cells don't lie. And there's a HIV positive patient with a lot of abnormal lymph node, negative head and neck. And you have lymphocyte and plasmacyte with this gigantic nuclei. What is it? And they scatter in the background, and along with lymphocyte and plasma cell, and then some cohesive cells too sick to analyze. So I saw was some kind of lymphoma. However, all the immunos are negative. So just a malignant surgical biopsy. I gave up. Just take it off and analyze it. And they, this is a record of the cell. You have the humongous nuclei. And then you have some plasma cells and some other area with vesicular chromatin. And it is the metastatic nasopharyngeal carcinoma. So I couldn't believe it. So I went back to the smear. How could I miss it? So I looked closely at those cohesive fragments, and then I found the similar cells, vesicular chromatin, identical to this. So that was interesting. A Chinese man with a nasal mask. Here's a small blue cells, nuclear size 10 times. So it's definitely malignant. No lymphogranule bodies. So it's not lymphoma. Ultrafast PET, salt and pepper, so it's neuroendocrine. You get immuno, synaptophysin positive, but cytopatron negative. Because it's neuroblastoma, of course, cytopatron negative. And because it's from the nose, so it's olfactory neuroblastoma. So that's how I signed it out at Bellevue. And then patient under chemo and the residual tumor had histology confirmed. Cells don't lie, remember that. Now we're talking about neck cyst. If you get a distal water-like fluid, you already know what it is. It's parathyroid cyst, and so just send it for parathyroid hormone assay. Or you could just put a drop, do not stain, air dry, lower the condenser, you see crystals. Recently, I discovered if I let the droplet, don't make a smear, make a stick drop, and let it completely air dry, wait 4 hours, then I do diff quick, the crystal structure remains. So I found it very useful. And another pocket avenue case that want to rule out metastatic papillary carcinoma with cystic degeneration. Dr. Messina did the aspirate, and grossly it's clear yellow fluid and not much cells on direct smear. So I brought this test tube back to the lab, centrifuge smear, and lo and behold, you see lymphocytes, mature lymph. Therefore, you put two and two together. Of course, it's lymphangioma. And confirmed by the total thyroidectomy because the surgeon did not believe me. Here's the recut of that. And here's a cervical lymph node with white highlight. So it's a pathological lymph node. It has to have something. And then you have cloudy cyst fluid, very few cells. Bring it back to the lab, centrifuge sediment, air dry smear. So it is metastatic squamous cell carcinoma. That's my approach to medicine. Here's a man with a parapharyngeal mass. Dr. Messina did CT guided FMA and shows a lot of neutrophils and then some cloudy substance, and then ultrafast paths show benign squamous cells, and then there's filamentous bacteria. So it is first bronchial plexus, acutely inflamed with actinomyces. Here's a case, sudden swelling of submandibular mass to tennis ball size. And Park Avenue FMA was Friday, last patient. Oh, it's just abscess, submandibular abscess. Wrong, false negative. I was informed I made a big mistake. So I asked for the recut for this cyst. It's squamous cell carcinoma arising from first bronchial plexus. So I learned a lesson from this mistake. So a year later, almost identical presentation. This time I did ultrafast testing and I saw angiophilic keratin. So I told Dr. Messina, make sure sample the cyst wall. And he got this papillary fragment. I even did a cell block and his cell block. So I just signed it out conservatively. Atypical bronchial plexus excision is required. And then patient had at Bethesda Hospital did the resection. It's confirmed. It's malignant first bronchial plexus. I have 3 cases, so we will share with everyone. So now I know, in addition to the common second bronchial plexus, submandibular areas, first bronchial plexus, and this is the lesson I learned. And there's a submandibular nodule in a woman, and so I thought it was a salivary gland tumor. But FNA shows, no, it's not salivary. It's very weird, a lot of cells, and they have negative images, look like naked nuclei. And then did the ultrafast PET scan. You have little thread interconnecting cytoplasmic process. And this is the feature of paraganglioma, and because at this side it's carotid body paraganglioma, and then you confirm it with immuno. So, and it's confirmed in resection. And so you compare the tissue and cytology, they're identical, except in cytology, you make a smear. So you separate the tumor cells and reveal the cytoplasmic processes. Just like if you do electron microscopy, you see the same thing. That's the beauty of direct smear. There's a baby boy with a sternal-masculine nodule with skeletal muscle, and then very small fibroblasts. And then you have skeletal muscle. So it's a fibromatosis coli. And here's the post-neck swelling intramuscular nodule. FNA show myxoid background substance with a lot of spindle cells with small nuclei. So it's diagnostic for nodular fasciitis. Here's a resection of that nodular fasciitis. Look exactly the same except different artifact. And posterior midline neck nodule, and the surgeon aspirates some bloody acid with spindle cells, small nucleus. And ultrafast PET stain shows in the center there's some kind of capillary connecting numerous very bland, benign spindle cells. So I just signed a local spindle cell neoplasm. I really don't know what it is, and anxiously wait for the answer. Here's the resection, and this is the aspiration with little capillaries and eosinophils. So a good surgical pathologist won't need any immunostain. They know immediately it's Mason's tumor, intravascular epithelial hyperplasia. So for the purpose of teaching, I did immunostain to show this endothelial hyperplasia. Posterior neck nodule, 10-year worsening of left arm numbness. So clinically, this neck nodule compressed it. That's why it was numb. And shows spindle cells, bland spindle cells. And on the ultrafast PET stain, you can see this myxoid substance. It's Anthony A. myxoid substance combined with the clinical presentation. Of course, it's schwannoma. And then I confirmed it with S400 immunostain after I signed it out, just for teaching purposes. And the patient waited 3 years before surgery until she couldn't stand it anymore and looked exactly like Cytology, ultrafast PET stain, because the PET stain is hematoxylin without eosin. So all the criteria for HME can apply to ultrafast PET stain, except there's no eosin. Maxillary sinus nodule. It shows big spindle cells. You could put like 4 or 5 RBC. And ultrafast PET stain shows a little bit necrosis, a little bit nucleated. So it just says suspicious for spindle cell sarcoma. and the histology showed fibrosarcoma. And enlarging TMJ nodule. This spindle cell, I could put 5, 6 RBC, so it's very worrisome. Even though ultrafast PET stain, the nuclear feature are not that ugly at all, but the big nuclear volume, I signed it suspicious for sarcoma. And then histology follow up the final diagnosis, monophasic synovial. Here's this African man came to Bellevue Hospital, and he had this cheek mass. Ignore the lipoma in his forehead. That doesn't bother me. And the fellow, NYU fellow, Cytohistology fellow, did FNA and shows some chondroid substance. It's too thick to look inside, and then some scattered tumor cells. RBC is like 5 or 6, but I still don't know what it is. But until I saw the transparent ultrafast PET stain, those are lacuna cells. Of course, it's chondrosarcoma, and it's confirmed by excisional biopsy. The patient was not treated because it would cut off his entire face. Surgeon had a patient with history of angiosarcoma of the nose, now with swollen upper lip with purple coloration. And on-site assessment that it's all blood, cell blocks, blood, diffuse, non-diagnostic, however, ultrafast PET stain. After all the blood has been hemolyzed, you see some cells go to high power and spindle cells. And so I get the compare with the previous nodule, this angiosarcoma. Same activate, they look identical. So I just signed a recurrent angiosarcoma. And here's a gum tumor. Lymph node epinate shows carcinoma. And this is the gum tumor, squamous carcinoma. And a woman with a blister behind left ear, history of melanoma of skull, and have diseased single cells, but they're very, very small nuclei. At high power, has vacuoles consistent with pre-melanism, and by the ultrafast PET stain, it had prominent nuclei. And there's no inclusion, so I did the immuno to confirm medicine. Filipino man with eye pain. Ophthalmologist did the FNA in the office and have cells with big nucleus, vacuoles in the cytoplasm. Ultrafast PET stain shows convoluted nuclei and cytoplasm vacuole. Because it's eye, so it also gets sample for cell block and confirm those are glycogen, so large cell carcinoma of the thymus gland. Patient refused surgery, and 2 years later, he had metastasis to the parotid. Chinese man with like a head-like scalp mask, really weird. FNA shows classic features of hepatocellular carcinoma. Here's the excisional biopsy. Lymph node, I rely on radiology. I refuse to look at the lymph node unless the sonographer gives me the 3 measurements. because I rely on that. In this case, Highland is very narrow, so I could start typing it's reactive lymph node. It has to be reactive because growth rate is normal. You shouldn't even biopsy. And so you have this classic presentation heterogeneous. I use this a lot. This one has a thick kind of it has to be some pathology. If I don't see anything, I'm going to sample flow. Fortunately, I saw granuloma in a clean background. So sarcoidosis is the histology of sarcoidosis. Bellevue case, they want to rule out lymphoma. That's the beauty of IFPRIC state. It's that negative images, and it's MAI in macrophages. That's the beauty of IFPRIC state. And some lymphoma are very straightforward, like this monogamous population of medium-sized lymphocytes. This lymphoma is cytologist's best friend with lipid vacuole and Burkitt's lymphoma. You don't need any fancy hematology workup because if I don't diagnose right away on Friday, by Monday, I'll get a CSF sample with metastatic Burkitt's lymphoma. This has a white highland and a young person with big cells with a recent cell, so it's Hodgkin lymphoma. White highland growing lymph node. Should I do flow or should I do cell block? I just have lava lymphocyte. I say flow cytometry, and then it's monoclonal CD10 positive T cells, so follicular lymphoma. Then for interest, I went back to ultrafast small clean cells. Here's a lymph node with previous history of high-grade lymphoma, and then you have dual population of small lymphocyte and large lymphocytes, and it has a vague follicle. And so based at clinical cytology, it's a recurrent high-grade lymphoma. However, flow cytometry is negative, but I use cytology clinical to ignore flow cytometry. I just signed it out recurrent follicular lymphoma. So it was excised. It's follicular lymphoma confirmed. So how come the flow cytometry was negative? This lymphoma happened to have very thin kappa restriction. So cytology clinical are very, very important. Matted lymph node, so it has to be malignant. And then I see a lot of small blue cells. I said, of course, it's possible, but do I need flow cytometry or cell block? I'm looking for lymphoglandular body, the clue. And then I found lymphoglandular body. So I said, flow cytometry. And this is Atlantic cell radiology case. Ultrafast PET stain shows hallmark cells and a plastic large P1 lymphoma. And flow cytometry confirms CD10 positive. So salivary gland FNA, Caribbean woman with rather large parasa. She couldn't even close one eye. Emergency room at Bellevue Hospital, ENT consult did the 2 air dry smears sent to Cytology. One was difficult, another was ultra fast patch. And it's a very easy diagnosis. It's a high-grade lymphoma. And then they want to work it up, repeat FNA by the flow, different flow, everything. And they also, the excisional biopsy shows parenchymal primary. And even did PCR because they want to touch patient. And so it's primary carotid lymphoma. And patient facial paresthesia improved after 1 cycle of chart. So published case report. Cornell case HIV positive submandibular nodule. FNA in-house patient is a tumor of reactive spindle cells, land spindle through immuno for LANA. So it's capillary sarcoma, no neutrophil. Parotid nodule, this all of you know this is membranous basal cell adenoma. It's a really old case. This parotid nodule with oncocytic cells. Look at the nuclei. They're really small, 1 times RBC. But for political reasons, it's signed off as oncocytic neoplasm. Here's the resection at the hospital. Oncocytic adenoma. Another case, lobulated parotid nodule, fluctuating in size. It has a cyst and then some oncocytic cells. Look at this nucleus volume. I could put 20 nuclei in the nucleus, so it has to be malignant. So I just signed out as parotid carcinoma. And the final diagnosis was ductal carcinoma, salivary gland, with cystic degeneration. All of you are very familiar with cystic carcinoma. They have, all of you know this, but I want to point one thing I rely a lot on, because sometimes 5% of pleomorphic adenoma have cylindromatous stroma, and when I saw it at Park Avenue radiology, it is cystic carcinoma. So I did the ultrafast PET stain. It has gland nuclear abundance cytoma. Oh no, it's not. Thank goodness, it's pleomorphic adenoma. And here's the histology. Because one of my colleagues signed up everything as cylindromatous tumor, so I want to convince him that let's do a project, pleomorphic adenoma versus adenocystic carcinoma. At high power, you can see pleomorphic adenoma have abundant cytoplasm. Adenocystic, you cannot see cytoplasm. So we did the electron microscopy because adenocystic carcinoma, the cytoplasm is less than 1 micron. It's beyond the resolution of light microscopy. So I use that a lot. Here's a classic case of intermittent pain and irregular ultrasound. And then you have cylindromatous stroma, naked nuclei. It's straightforward, cystic carcinoma. And this resection show classic case with neural invasion. And this is, everybody's familiar with this cribriform pattern. However, I had another pattern. It's very difficult to recognize. I had a kinetic woman had a small nodule at the FNA at Park Avenue Radiology, and she was very upset. She said, "I'm going to sue my doctor in Connecticut." He said, it's nothing," and I waited for 2 years. So I was very scared of her. And it shows a lot of tubules with naked nuclei, but they're not cribriform. It's really strange. A lot of tubules, almost like inside out. Here's the low power. And I use oil immersion. Look at the chromatin. They're naked, and chromatin's atypical. So I just signed a suspicious for agnosis. Because she's a very aggressive patient. I'm very afraid of her. And she had surgery at Memorial Hospital, and I had a recut. It's agnosis. And another case, like a parotid swelling, the whole parotid swell. And FNA show a lot of mucin. Since parotid is a serous gland, why would you have mucin in serous gland? It's not normal. So immediately I was suspicious for mucoepidermal carcinoma. And on difficult stain, I see a lot of small blue cells. Initially, I thought it was lymphocyte. But I said, how come they form like a school of fish, so well formed? So I did ultrafast PET stain on site. So thank goodness I did that. And it's not lymphocyte, it's epithelium. So now you have abundant mucin and benign looking epithelium. So it's suspicious for low-grade mucoepidermal carcinoma. And because his swelling is all over, diffuse over the parotid, so a lot of surgeons refused to operate because too much trouble. Finally, we found a surgeon that either spent 8 hours carefully dissect the mucin, and then finally I got the recut from a former Cornell Cytohistology fellow, now working at Bethany as a attendee. Here's the recut she gave me, just low-grade mucoepidermal. And sometimes parotid FNA, you have a lot of it's straightforward. You have a lot of mucin, and then you have epithelium. So it's straightforward case. It's mucoepidermal carcinoma. This case, the challenge is to sample the epithelium. It's not cytologic diagnosis. Another interesting case, it's a recurrence. Otherwise, I would never diagnose this. But I want to share the cytology with you. There's some secretion, not exactly like mucin, a little bit like mucin, a lot of scratches, and with small nucleus, some vacuoles in the cytoplasm. Here's the original mucin positive, and it's a recurrent secretory carcinoma of parotid. And another case, slow-growing parotid nodule, with a lot of blue material, and then purple metachromatic substance. And some look a little bit like mucin, but it's hard to tell. I go to high power, look at the nuclear, the abundant cytoplasm. So I really don't know what. I just find out it's pleomorphic adenoma with a cylindromatous pattern, and they took it out on frozen section. Was also called pleomorphic adenoma. Here's the ultrafast PET stain with a lot of concretions and some purplish mucin-like substance, some concentric concretions, very bland nuclei, like pleomorphic adenoma. Here's a frozen section, just they just signed out as pleomorphic adenoma. But when they study entire tumor, they find out their invasion, and you look at carefully, it's adenocystic carcinoma. But how come there's so many concretions? And I did the cytokeratin stain showing the epithelium are destroyed on the right-hand panel because it's amyloid destroyed cells, and the left are cell-rich area. And so here's the Congo red with polarized, like with apple green fiery fringes. Amyloid. So this case is amyloid-rich low-grade adenocarcinoma parotid. And maybe you will never ever run into a case like this, but I was interested in this case because it shows how amyloid formation and then destroyed the tumor cells. And because when I was a resident at NYU, did research in renal pathology with amyloid. Here's a Bellevue case, parotid with serous fluid. So it's okay, serous gland, serous fluid. But you have tumor cells. It's clearly not normal salivary gland. It has promonucleoli, bacterial cytoplasm, and they have promonucleoli because they have protein synthesis. They make a lot of serous fluid. So it's a cynic cell carcinoma. Here's the histology, shows exactly the same thing. Cytology is the component of histology. I love cytology, histology correlation. To me, it's like a puzzle, like Sherlock Holmes. You try to figure out what it is, and then you get the answer in histology. So, father of ENT surgeon, he referred his father to Lennox cell. No, sorry, that's not the case. This is a case at the University of Pennsylvania with a fellow, a submandibular nodule. It's a console case from outside. It has small blue cells. It is lymphoma, but you have rare cohesive cells. And then the console use H&E stain has a very salt and pepperish to neuroendocrine tumor. Cytokeratin positive for dot-like. So this is a gross specimen, shows this tumor with small blue cells with dot-like cytokeratin and neurofilament. And we Dr. Gupta and I did the electron microscopy study because I'm really interested in this interfilament dot-like substance, the electron microscopy retrieve tumor. And here shows interfilament button. So when you make a smear, the button pop out. And that's the clue for Merkel cell carcinoma. So 2010 Cornell surgeon had the parotid nodule, had positive small blue cells. There's no lymphoid glandular body. And then with a lot of substance, could this be interfilament buttons? And to site immuno on cell block, cytokeratin dot-like, so it is. So I have all the evidence to call this Merkel cell carcinoma of the parotid. And here's the histology follow-up. It's the same. This is the last case. A father of an ENT surgeon with a big, long-standing, slow-growing parotid mass. Ultrasound showed circumscribed mass with solid cystic area. And Dr. Messina did FNA on the cystic area. It's not mucin, it's serous fluid. Okay. And he sampled solid area, had cohesive epithelium. Could this be Walton's tumor? So I did ultrafast PET stains. Oh no, it's not Walton's tumor. It's a malignant nuclei. And with some vacuoles, I would thought, could this be nucleoepidermal? I just signed up parotid carcinoma. Give a whole bunch of differential. And histology follow-up show it's a tumor with dual differentiation. Has myxillary cells and ductal cells. So was epithelial myxillary carcinoma, ductal predominant. So I went back to cytology, and I want to know what's the cytologic clues. Here's the concretion I thought was mucin, but it's not, just PS positive, mucin negative says concretion. And then I thought, okay, here's the malignant epithelium. What about the myxillary cell? Where is it? I don't see anywhere. So I keep looking, and I changed the focal plane. Voila, I saw the neoplastic myxillary cells. And so then I was satisfied. It's just for like my hobby to do cytology, histology foundation. So I have shared with you the cases: granular cell tumor, pyelonephrioma is squamous, depending whether it's lymph node or subcutaneous. Nasopharyngeal carcinoma, the usual and a weird case, HIV positive patient. And I show you olfactory neuroblastoma, that's cytoplasmic negative with the smelling nasal. And I show you different kind of cysts from parasitic to lymphangioma, squamous cell. And the approach, the growth appearance. Growth is so important. Growth pathology is so important in everything. And then I have shown you bronchial cyst denied versus malignant. I show you paraganglioma. And larger fasciitis, Mason's tumor, schwannoma, fibrosarcoma, synovial sarcoma, chondrosarcoma, angiosarcoma. Cytology has its limitations, but it would never replace surgical pathology. But it's a very quick, inexpensive method to help triage the patient. And, and then I show you tumor squamous cell carcinoma of the gum with metastasis, the eye, the ear, melanoma, and then the skull metastasis from liver. And I show you these sarcoidosis, MAI, and I show you recognizable lymphoma, cytology's best friend, Burkitt's lymphoma, Hodgkin lymphoma. Those are cytology's best friend. But Hodgkin's lymphoma, there's a pitfall. Sometimes you could have Hodgkin-like non-Hodgkin lymphoma with big cells. It's like a large B cell in the background of T cell. And I show you a lot of lymphoma. It's very difficult to recognize in cytology. And thank God we have flow cytometry to support it. And whenever I have a lymph node, the most important is the hyalin. I could have a 4 by 0.8 by 3. It's reactive lymph node. But if I have 2 by 1 by 2, it's pathologic lymph node. The clues are ultrasound. And you have to, in the level, first clinical, then radiology, then cytology in that setting. This way you avoid mistake. And I show you flow cytometry is not everything. Some lymphoma are flow cytometry negative, or some high-grade lymphoma, the cells die so fast. And another best friend of cytology is lymphoma with Homa cells. And I've shown you primary parotid lymphoma, capillary sarcoma, and everybody knows this membranous basal cell adenoma. And also I show you oncocytoma and with very small nuclei on big quick stage. Salivary gland tumor, and then another tumor with big 50 times RBC, it's a salivary gland carcinoma. And I show you cylindromatous femoral thick adenoma versus adenocystic carcinoma. And I show you tubular variant of adenocystic carcinoma. Show you low grade versus the usual mucophthalmic carcinoma. Show you a recurrent secretory carcinoma. A case you'll never encounter amyloid-rich low-grade adenocarcinoma for fun. Adenocystic carcinoma and Merkel cell carcinoma with the intermediate filament buttons and ductal predominant epithelial mouthfeel carcinoma. So that's all I have to say. Any questions?
Thank you, Dr. Yang. That was a great lecture. I will invite the participants to find either the chat or the Q&A windows to type any questions they have for the speaker, and I will read them to her. Just ask that if you use the chat window to be sure you're directing it to either me or all participants. If you send it to the speaker or other people, that I won't be able to read it to the speaker. And then also just while we're waiting for questions, just a reminder that if anyone came in late or would like to review this, it will be present archived in the proprietary WebEx player format on the accessible through the IAC website. So you can review all these great cases and great photographs. While we're waiting for questions, I was just curious to ask the speaker how, to maybe give a little bit more. I was just curious more information about the rapid PAP and how she became interested in using this technique. Was there a particular circumstance or case that kind of led you to it?
Yes, because I was trained at University of Pennsylvania by Dr. Gupta, and his fellowship, he stressed on-site diagnosis, and we used to do a lot of intraoperative pancreatic FNA on DIPQUIC only, and based on which Whipple will be performed. So it's very scary. And although I'm pretty good in DIPQUIC, but DIPQUIC has its limitations. I wanted a quick, really quick PAP stain, so to avoid false negative cases, because DIPQUIC, everything looks malignant. So I said I have to develop this PAP. Also, I don't like the blood. It just annoys me. It's okay in DIPQUIC because I use as measurement, but on say PAP stain, it's red blood cell everywhere. I can't. When I take a picture, it's not beautiful because I want beautiful cytology. I want all the blood disappear. So I and the fellow Alvarez, we just embarked on this. And finally, the key thing is air dry rehydration by John Casey Chen of Hong Kong. That makes a huge difference. And because with air dry, because everybody's afraid of air drying, you have air dry artery. But if you air dry completely and dip in normal saline, all the red blood cells will disappear. And the cells will rehydrate, become beautiful, transparent, clean background. And then I wanted fast enough so I could tell patient right away. And if I could make it fast until I put a little bit formaldehyde in alcohol fixative, then just very quickly it's fixed. If I skip the formaldehyde, then I'll have to wait 10 minutes. And nobody could wait that long. Patients very anxious. And so, so once I add alcoholic formalin, voila, it very quickly fixed. And then you have beautiful, beautiful nuclear detail. Here's the diagram I made. You see, where fixed cells, you have a lot of blood, you have 3D cells. Cells are smaller, cilia are 3-dimensional, but once you air dry, they're completely flattened on the glass slide. They're totally flat in same focal plane. And then you rehydrate, it become all transparent again. So you have bigger cell, more cytoplasm, you could analyze it clearly. And that's why, so once it's developed, asked my husband make me a small container, put miniature jar. So I took it at Cornell, York Hospital, whenever surgeon or anybody want or intraoperative, I have both ultrafast PAP and DIPQUIC, and did a lot of intraoperative. And the surgeon was thrilled. So they told Park Avenue Radiology owner, oh, we have this cytopathologist who could give you immediate diagnosis. And they said, oh, gee, it's a great way to make money. That's the pitch. While you wait, you'll get diagnosis. And they came to see me. I said, no, I'm a pathologist. I can't go. And then I went to Chicago for AAC meeting. And then when I returned, Dr. Knowles told me that Dr. Messina, Dr. Levitsky has already came to see him. He said, of course, Grace can go. You want her to go 1 day a week or 2 day a week? So I had no choice. I had to go. And at that time, I was only 3 years out of fellowship training. But I have this weapon in my hand. And I told Dr. Messina, I said, I'm only 3 years out of training, so my diagnosis, I have a lot of atypical suspicious. As I get more experience, I'll be more definitive. And so all the decisions I have to make, malignant, negative, or I don't know. I don't know means suspicious or atypical. It's very straightforward because at that time, there a lot of breast acne, ductal carcinoma, fibroadenoma, larval carcinoma. That was before the core biopsy in the United States that took over the entire breast acne. But back in 1995, and there's so many breast acne, and I use this two weapons to provide patient the answer. And so I'd like to share with you. That's all I have to say.
Yeah, thank you. I mean,